Allowing me to go ahead without presentation. It's really very proud moment for me to present my view on atherosclerotic cardiovascular prevention. And it is a very important subject, as we all know that the high morbidity and mortality associated with this disease. Cardiovascular disease comprises of coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Majority are due to atherosclerosis. In India, cardiovascular death is quite high, as the previous speaker has already said. It is 272 per thousand population and more than the global average 235 over 100,000 population. So actually the prevention came in limelight after the first time Birmingham heart study was done, and it was pointed out that the concept of risk factor is very important in preventing cardiovascular disease, atherosclerotic cardiovascular disease. And we all know that atherosclerotic cardiovascular disease passes through various stages. First, there is a genetic susceptibility, there is a lifestyle behavior risk factor, then comes into play the biochemical and physiological markers like abnormal lipids, high blood pressure, hyperglycemia, diabetes, obesity, and new markers. Then the third stage comes of the subclinical disease. Subclinical disease is very important nowadays, and we can detect by carotid intimal media thickness, coronary artery calcium, and by detecting endothelial dysfunction. Then comes at the end the clinical disease, which is a very, very late stage of atherosclerotic behavior. Traditional risk factor has already been mentioned by previous speaker: hypertension, dyslipidemia, and variety of lipid abnormality, especially high total cholesterol, high LDL triglyceride, non-HDL cholesterol, low HDL cholesterol, high lipoprotein A, apolipoprotein B, apolipoprotein C3, and small dense LDL particles, glucose intolerance, smoking, and family history of the premature coronary artery disease. By premature, I mean when the male suffers from the coronary artery or atherosclerotic disease before 55 years, and the female gets it before 65 years. There is a genetic susceptibility in 40 to 60% of the cases, and there are 33 genetic variants so far has been described. Maybe more is coming in future. The significant levels we should note in lipids, particularly when LDL cholesterol is more than 160 milligram percent, triglyceride is more than 175 milligram, lipoprotein A is more than 50 milligram percent, and apolipoprotein B more than 130 milligram percent, and high sensitivity CRP more than 2 milligram per liter. These are important levels which are very significant in development of atherosclerotic heart disease. There is traditional risk factor other than these, like high BMI, visceral obesity in particularly, high age, physical inactivity is very important, psychosocial factors like depression, anger, stress, and so many other factors. These may lead to premature coronary artery disease, acute coronary syndrome, and sudden cardiac death. The emerging risk factors is a focus of the attention in recent time, like high hsCRP, high interleukin 6, membrane-bound interleukin 6, increased level of leukocyte enzyme myeloperoxidase. All the three, they denote inflammatory changes which is going on in atheroma formation and progression. HIV positive status, mediastinal chest wall radiation, metabolic syndrome, microalbuminuria, and remnant lipoprotein. Microalbuminuria, we don't know what is the direct link, but it has been stated that it is definitely important in a marker of the atherosclerotic coronary artery disease in future. Now, risk enhancing factors. After all these risks, there are certain situations when there is all these risks, they get amplified, like family history of the positive coronary artery disease, primary hypercholesterolemia, metabolic syndrome, chronic kidney disease when GFR is between 15 to 59 milliliter per minute, chronic inflammatory condition like psoriasis, rheumatoid arthritis, lupus, HIV, etc. History of premature menopause in less than 40 years, or history of preeclampsia, high risk ethnicity like South Asian ancestry. Now, what is the coronary artery disease risk equivalent? Previous speaker talked about this, but Association of American Cardiology, they say that risk equivalent is just like having a severe risk of 20% magnitude. Like if you find atherosclerotic disease in coronary artery, in carotid artery, or in peripheral artery, or in abdominal aortic aneurysm by ultrasound, such cases do represent a very high CAD risk of 10 years exceeding 20%. Similarly, the risk equivalent are diabetes, insulin resistance, hyperinsulinemia, and elevated blood sugar. Hyperglycemia without overdiabetes. Many people think that the blood sugar is only slightly raised, but I don't have diabetes. But this is not true. Even the hyperglycemia without overdiabetes is a risk. Chronic